Hello, everybody. This is Dave Crawford, Director of Training Development for CASAC Trinity. And today's training is about assessment and diagnosis. I decided to make this training because I know over the years, I've seen a lot of confusion in this area. I've seen counselors and myself struggle. And I figure it would be wise kind of just to lay out a guideline and format, a way to think about these things. I am going to get into it a little bit later, but I know one common mistake that I have seen, and not like super common, but enough. I've seen enough where it is concerning is when we're doing a chemical dependency assessment, comp evals, the psychosocial, it is not just what the client reports to us. It is not just what they tell us in that moment, because there's a saying, if you're not familiar with it, I've been hearing it for years, that clients are their own worst historians, but also, also, if we're going to just, if you've been working here for a while, or if you've been in the field a while, you know that at times clients don't necessarily want services. And even though that, yes, we want to try to work with that and roll with that resistance when we can, at the end of the day, we are the professionals. We are trained to do these assessments and make our clinical recommendations. Just like if someone goes to the doctor's office because they're feeling faint and they find out they have blood pressure issues, the doctor is going to prescribe medication and a course of treatment, and it is up to the person whether or not they follow it. Same thing with diabetes. Someone all of a sudden has increased blood sugar and things that come along with that, and they go and they find out they're type 2 diabetic. The doctor's going to recommend a course of treatment, dietary changes, and insulin. And again, it's up to the patient whether or not they follow it, but the doctor's still going to recommend what that it is. And it's the same with us. And I think that we maybe because we're not doctors, then maybe we feel it's not the same, but it really is. I mean, that's what we're trained to do. That is what we go to school to do. That's what we become QHPs for. And it is our clinical recommendation. So yes, we can't make anybody do anything. We can't make people follow the recommendation. They might attend the eval appointment and never come back again. That is not our business. Our business is what are we seeing, what symptoms are exhibited, and to collect that information. Yes, there are clients that will come in and be completely transparent and lay it all out for us, and it's that easy. And then there's other ones that might be a little evasive, or maybe not even evasive. Maybe they quite don't understand what we're asking. So I want to make this training to address that, to go through criteria and kind of unpack how it could be framed to increase client understanding, because I do think that if we're asking the diagnosis questions in a way that's verbatim off the DSM, then it can get a little confusing at sometimes. Like, we've been doing this for a year and we know perfectly what it means by does your use ever exacerbate mental health or medical symptoms. The client might not quite understand what that means. So there's just ways to ask that kind of stuff. Before going further though, I do want to emphasize, and again, I'll get into it a little bit later in this training, it takes collateral contact. It takes calling family members. It takes calling probation, parole officers. And anytime you have a sentenced inmate, by the way, like on probation or parole, treatment court's a little bit different, but probation, parole, they will have a pre-sentence investigation, which typically gives a whole client history, like going back to childhood. So that's a great source of information when you're doing your assessment. If you're in an area where you might know diagnosis exists, but clients reporting no use, or you just want to get a more accurate picture, you might need the pre-sentence investigation. So I cannot emphasize that enough, because I think it's severely overlooked. Client comes in and says they don't know why they're here, they don't want to be here, and you don't even call and get like a report from probation why they were sent in to get an eval. I mean, in many cases, they could have had 8 positive screens, or maybe you find out about that, but because there's some misconception around that, you just go by the client report. Even if there's 7, 8 positive screens from probation for meth or for opiates, and the client's saying they're false positives, I don't think we should be kind of going with that report from the client. And we kind of got to go with the information we're getting from probation, especially if we're collaborating it with a PSI and some family members report. So like I said, this training is not going to be the most exciting. Basically, we're just going to unpack most of the all the criteria and talk about a couple key points. I do have a couple videos in the beginning I'm going to show, because when I was looking to put this together, they don't necessarily go through the criteria verbatim, but they do like show what that looks like in real life, because that's what we're looking at. We're looking at, I mean, people drink, people smoke weed, and it doesn't have an impact on their life. Maybe they go out, they smoke a joint at night once in a while or on the weekends, or they have a beer with their, go to the bar one times. And sometimes on occasion, we'll get a client that had a BAC of 0.08 right there at the bare minimum, had 2 drinks and got pulled over and has no history. And yes, they don't need treatment. But I will say, when I'm training people, and I want to say it now, we do not work in a setting where people just walk in off the streets and say, hey, let me check this out. I wonder if this is going on in my life. 95% of the time that people get sent to us, they need to be with us, whether they want to or not. And again, we can't make them be with us, but if we're not even accurately assessing, diagnosing, then we're doing a disservice to that person. I really feel that, because I mean, it is so common. We've all been trained motivational interviewing tactics, like resistance is very much a part of our field and kind of almost what makes it unique. I mean, if I hurt myself and need to go to the doctors, I know I need to go to the doctors and I want to feel better. We work in a field where clients don't always want our services initially, and they're not even ready to look at the kind of negative consequences their behavior might be having on their life. So they don't want to be here. That doesn't mean they don't have the symptoms though. And that's what we're talking about today. You know, like there's so much of our work that is subjective. Assessment and diagnosis is not. It is completely an objective thing. You cannot go on your feelings. You cannot go on the client's feelings. You cannot go on your opinions. You need to do what you're seeing, what the client's reporting, and all the extra information you gather and your collateral context for your assessment. So with that said, we'll move on to the first video. I put the videos both in a row because they kind of go what symptoms look like, and the second one specifically unpacks diagnosis a little bit, but not as in depth as we're going to go. So I'll be back.
A glass of wine helps me relax.
My doctor prescribes these painkillers for me, so it's fine I still take them.
Meth has taken everything from me.
I understand what rock bottom means. These are the voices of substance use disorders. They are young and old, rich and poor, from every ethnic group, religion, gender, and sexual orientation. And one of those voices is mine. I've learned a few things through this journey. One thing I know, addiction doesn't discriminate. Our crave for substances takes over our lives. We become dependent on them. We make dangerous decisions as a result. We lose the things that mean the most to us. I know because it happened to me. This is what medical providers are talking about when they say substance use disorder. It is called mild, moderate, or severe based upon the number of symptoms and problems you have. Every substance has its own diagnosis. So you might hear people say alcohol use disorder, tobacco use disorder, cocaine use disorder. Here are a few of the things that people say they experience.
1. They develop tolerance to the drug. This means if you used to feel tipsy with 2 glasses of wine, you start to need 3 to get the same effect, then 4. 2. They feel withdrawal when the substance leaves their bodies. Withdrawal is when you feel horrible, and the only way to feel better is to use again. 3. They take risks due to the substance. This could be driving under the influence or other dangerous behaviors. 4. They spend a lot of time thinking about the drug or figuring out a way to get it, take it, and recover from it. 5. They stop doing things that used to mean something to them. They miss work or school, and they withdraw from their friends and family, making excuses for missing events. They have problems with the people in their lives. 6. They take more of the drug than they wanted to. They might head to parties with the intention of having 2 drinks and driving people home, but they end up too drunk to drive, and sometimes driving anyway. 7. They crave the drug. This can feel physical or emotional. Craving is real, and it's painful. They want it to stop, and using helps the feeling go away. You know that feeling you have about the first cup of coffee in the morning? That's a craving. With other substances, that feeling can be much more intense. 8. Many times they want to cut down, but they just can't. Not without help.
If you've noticed any of these symptoms, you might have a substance use disorder. There is hope. Treatment works. There are many ways to treat a substance use disorder. Treatment can range from inpatient treatment to detox to 12-step support groups in your community. Talk to your medical provider. Living with a substance use disorder does not mean you are weak. Treatment works. People go on to live fulfilling lives. I know, I've done it.
So I'm only going to talk about it briefly because the second one's very similar. The second one gets a little more detailed as far as criteria goes, but again, doesn't go as far as we're going to go today. However, I think it does kind of show how that negative use impacts life and what may differ from a person who might occasionally drink compared to a person who has a problem drinking, problem with alcohol. And again, I mentioned alcohol and weed. I would say those ones are ones that people may have a history of. That doesn't necessarily mean they have used it more often. I think we start getting into the harder drugs. Yes, especially in a progression, it might not be to a level like, I mean, I think about like college kid in school that sniffs some cocaine once in a while, like maybe never got out of hand. I don't know, but typically, especially if you start getting like crack, heroin, meth, like, yeah, the first couple times might be just kind of experimental, but those are kind of ones that hook you quick. So if you got clients with history of that, I mean, that's not even on the table. Like people just don't shoot heroin and not have problems associated with it, for example, you know what I'm saying? So we'll go a little further and watch this next video and then we'll unpack the criteria.
Okay, let's consider drugs. I'm also going to call them substances. And as you know, there's a whole bunch of different drugs and substances that people use. Some of the most common ones include alcohol and tobacco, but also there's a range of other ones including cannabis, opioids, that includes things like heroin, also things like stimulants, and that includes things like cocaine and amphetamines, and a whole bunch of other things including hallucinogens, and that includes things like LSD, inhalants, hypnotics, sedatives, and other things. And let us not also forget one of the most commonly used substances, which is caffeine, commonly found in your mug of coffee or tea. So when we look at drugs, when we consider drugs, there's several things that we have to also kind of look at. So we have to consider what happens when drugs enter the body and also what happens when they exit. And these are two different processes. The first process would, when the drug actually goes into a human body, we can actually call this intoxication. And that's when the drug exerts its effect on somebody when it goes into their body. And if it exits after a period of prolonged use, we may experience something called withdrawal. So what are we talking about when we mention intoxication? We're talking about both the behavioral and psychological effects of the drug on the person. And these can be very much drug specific. So can we think of some examples of intoxication? Well, let me give you a couple of examples. When we're drunk, that's an example of intoxication with alcohol. Or when we describe somebody as being high, that again is a lay colloquial way of describing when someone is intoxicated with another substance, which may be something like cocaine or heroin, for example. So what about when a substance actually exits a person? Well, withdrawal happens when we stop taking a substance after having taken it for a prolonged period of time. And what happens there is that we get withdrawal symptoms of stopping the drug. And these symptoms can make us feel quite sick or ill, and in some cases can be quite dangerous or potentially fatal, depending on the drug. And when I say drug, should also say substance here. That's a more formal way of referring to it. And both intoxication and withdrawal, the effects really vary on the precise drug or substance that we're using. But let us also think about drugs or these substances in a different way. Let us think about them on their effects on the human brain. Well, we know these substances can actually result in a whole heap of other conditions because they can result in something called substance-induced disorders. So these are conditions that are actually caused by substances. And these are conditions that could be substance-induced mood disorders, disorders of mood, either experiencing moods that are too high, like mania, or moods that are too low, like depression, disorders related to anxiety, sleep, sexual function, We may also get problems with something called psychosis, which is a loss of contact with reality, and that's where people can hear voices or see things, or become very paranoid. Now, when these drugs affect the brain, something completely different may also happen. We can actually have the development of a substance use disorder. Now, not everybody that uses a substance develops a substance use disorder, which basically implies that when they use this drug, the way that they're using the substance or the drug is causing them a real degree of impairment. It's really affecting the way that they function in their life, whether that's at school, work, or home. Their drug use is really impairing. Now, let us talk about substance use disorder a little further. Because when we talk about substance use disorder, the main issue that we are looking at is that there is a problem here. There is a problem with their substance use. And again, not everybody that drinks alcohol or smokes cigarettes or uses illicit substances, not everybody has a substance use disorder, but some people do. So let's have a closer look at this. So how do we know they have a substance use disorder? One of the ways that we can find out is by looking at their use. And there's really important factors that we need to consider here. Are they using increasingly large amounts? Are they experiencing increasing craving or strong desires to use? Are they spending more and more of their time recovering from or trying to get the substances? Are they failing to try and cut back or cut down? And also feeding into this use issue, are they experiencing problems related to their obligations at work, at school, at home? If these things are appearing, that really does suggest that maybe there is a problem and maybe they have a substance use disorder. A second factor that we look at, apart from use, is the presence of something we talked about earlier, and that was the presence of withdrawal. Now, this is something that happens after you stop using the drug after prolonged or sustained use, and you can feel pretty sick or unwell with different symptoms depending on whatever drug you're using after having stopped the drug. And this really also suggests that so physiologically you're dependent on the drug, your body's dependent on the drug. And withdrawal can be dangerous. For example, alcohol withdrawal. You can get seizures potentially and die. And withdrawal symptoms are specific to the substance. So again, the presence of withdrawal suggests that you have a problem. Finally, the last thing I want to mention is the presence of something called tolerance. And what tolerance is, let me graph it out for you. If this is the effect and this is the dose, the effect of the drug decreases with subsequent doses. Your body adapts to or builds a tolerance to the substance. So what people do in order to overcome this tolerance is they tend to keep increasing the dose or the amount of the substance that they use in order to achieve the same level of intoxication. So as we can see, the way that people are using and the problems that they are encountering with the substance, the development of withdrawal symptoms and the development of tolerance all suggest that we have a problem. And actually just having a couple of these, such as craving or withdrawal or using increasing amounts, not being able to cut down, is enough for us to be able to diagnose a substance use disorder. And there's different severities of substance use disorder from mild, moderate to severe. The one caveat I would say is that caffeine, of all the drugs that I've mentioned, with caffeine, we cannot develop a substance use disorder according to the current criteria. Now, that may be an arbitrary thing, but I just want you to know that.
I would definitely agree with the caffeine, a little arbitrary thing, because yeah, we're not diagnosing anybody with caffeine disorder. Before we move on and get fully into it, I do want to talk about a couple of things. Showing the video going in, I plan on talking about the problems associated in the person's life, because that can vary substantially. There's like a spectrum of it, if you will, and it's much easier to see a homeless person underneath the bridge than someone who's married and has a house and job So there we want to unpack things thoroughly, because it doesn't mean it doesn't exist. And that goes with that mild, moderate, severe. And we'll talk about that in a second as well. But watching the video also made me think about tolerance. And because tolerance is at the end of this, I want to talk about it now before I forget. So I'll probably bring it back up, but let's talk about tolerance for instance. Let's specifically with alcohol. I mean, tolerance by general, we start talking about drug use. And like I mentioned earlier with the meth and crack, heroin, like cocaine, person starts and we have someone crack cocaine and they started and they tell us they did a couple lines the first time they did it. And then they started using cocaine more. And this can vary, obviously. This isn't everybody's story, but I think it's a common one. And then they tried crack cocaine and they're using 100, 200 hours worth a day. It's easy to see the tolerance there. Alcohol, I think it's underlooked a lot. Anybody watching this that works for CASAC, I mean, we also work in a field that we have people that have history and we have people that don't. Anybody with history, I think you're gonna know what I'm saying. Anybody without history, if you drink on occasion, I think that you will not deny this. So a typical person might have a couple of drinks and they're feeling a little loopy, 1 or 2 glasses of wine, and they're feeling something from that they're having a buzz. And it's not even saying that they might go out a couple times a year and have 6 drinks and just, yeah, that just floors them. You know what I mean? I think that when we're doing an eval and someone's reporting that on average, they drink 4 to 6 drinks in a setting and they do that a few times a week, that alone indicates tolerance to me, because a person that doesn't drink like that is not going to have that same effect. I mean, if they're drinking 4 to 6 drinks and they're not even like really buzzing and they're kind of talking, I mean, obviously they're not going to be that specific, but if that's the impression you're getting, that's a big indicator of tolerance right there. I know I also think about the IDS training. IDS, if you have a DWI and they're reporting that, no, they're not giving a lot, but they had a BAC of 0.14 or higher, 0.104 or higher per Oasis indicates tolerance right there. Because it's that, I would say that's about 4 drinks. It would be my guess. I mean, a 0.8 is 2 drinks in an hour. That 0.14 probably be 4 to 6 drinks in 2 hours frame, I'd say, on a best guess. I mean, I'm not going to break down all of it, break down the body, but I'm just giving an estimate. So I think tolerance gets overlooked a lot. And that's one where that client would say, no, I always drink 4 to 6 drinks. No, they didn't. They didn't. And maybe they don't recognize that when they first drink alcohol, it's been so long ago that 1 or 2 beers would have them feeling silly and tipsy because they were younger. And it's been so many years now that just seems like a normal thing. But yeah, if they're drinking 4 to 6 drinks and not even really feeling anything, that's a big indicator of tolerance. And I think that's one that we got to use our clinical impression on. So let me get back to the problems though. That is what we're looking at. We are looking at how this person's use of substances, alcohol, drugs, whatever, is negatively impacting their life. And I've been doing this for a while now, and I love all the new stuff we got, and I love how far this fields are coming. But I would say this one thing with the DSM-5 is what I don't like, because I worked in the field in the time of the DSM-4. And that time it was use, abuse, dependency. So a person's substance use, that they're not even meeting criteria and we're not even recommending treatment. Abuse doesn't necessarily meet a criteria for dependence. It's not, that's saying like, that's like the college kid that got a DWI and probably parties too much, but might grow out of that. You know what I mean? We don't know that, but they still abuse the substance. And then like them coming to treatment, doing some outpatient, kind of getting the flag on the play. They're going to learn some tools. It's not going to help them. And if their use progresses down the road, at least they already know what this is about and started a thing. If not, they move on and they go their own way. Dependency is a different thing. Dependency is that textbook alcoholic that just starts drinking in the morning, lost a job, might be headed towards homeless or be homeless. And same thing with drug addicts. I mean, the dependency is hard to say. Like they cannot function. Dependencies, they cannot function without the substance in their system. And with that would be our severe diagnosis that we're looking at. And I would, just to clarify, I would say that the abuse back in the old days would be the mild or moderate we have now. So just because a client might not be using to a point that they are homeless and have no job and all their families turn their back on me, that doesn't mean their use is still not negatively impacting their life and they're not fighting with their spouse all the time. Or even if they're working right now, they've had 5 jobs in the last year because they keep getting fired for blowing off of work or not coming in or just quitting or going to work under the influence. Like these are all different variances of what we're looking at and what us flushing the symptoms out. And might never get it perfect. I mean, we get a client fully disclosing their severe diagnosis. Yeah, they're going to give us all their history and that one's the easy one. There might be cases where we only get a moderate and it's really severe as we start working with the client. And that's okay, I think. I mean, we can only do the best we can. And if the PSI and we did all our due diligence and that's all we got is a moderate diagnosis, we still got them in the seat and they still started the process. And we're on the path to recovery and we're on the path to like helping them overcome some obstacles. So first I'm going to break down the criteria, just how it's written. Number one, taking the substance in larger amounts or longer than you meant to. Number two, wanting to cut down or stop using the substance, but not managing to. Number three, spending a lot of time getting, using, or recovering from the use of substance. And for that one, just has to be one, doesn't have to be all three. Cravings and urges to use the substance, not managing to do what you should at work, home, or school because of the substance, continuing to use even when it causes problems in relationships. Number seven, giving up important social, occupational, or recreational activities because due to use. Number eight, using substances again and again, even if it puts you in danger. Number nine, continuing to use even when you know you have a physical or psychological problem that could have been caused or made worse by the substance. Number 10, needing more of the substance to get the effect you want, tolerance. And number 11, development of withdrawal symptoms. So yes, that is it. And I know they're not like word for word out of the DSM, and I did that kind of purpose because I already kind of trying to frame it to think about it in a way that sounds natural and normal and to present it to the clients instead of kind of the technical way. Because if we're doing our assessments and we're just going through 1 through 11, just as they're written, one or two things are going to happen. There might be some cognitive impairments anyways, so the client might not totally understand. Or on some of them, I think unless you went to college and kind of understand what that means, you might not understand it even if your cognitive levels are fine. The other thing that's going to happen, if you've got an evasive client, especially if they've been through this before, they know what you're asking and they're just going to say no. You know what I mean? I think that this criteria part, I know that evals can be time consuming and they can be a little challenging because we're documenting, we're talking, we're trying to do it. But like, especially the criteria part, you want to start like, that's a normal conversation. You know, I joke with colleagues, but I also mean it. When I'm out giving that initial urine screen and with the client and I'm usually got 2-3 criteria before we even sit down and do the eval, just by saying, hey, what's going on? What are you doing here? Who's sending you in? That kind of stuff, just regular conversation. And I'll tell you, if you're new to the field, I know that might be challenging until you know the criteria. But after you've been doing this for a while, like you just know them by heart and you get to know what behavior around that kind of looks like. So again, if you're not there already, I would strongly suggest you try working on getting this diagnosis part more as a casual conversation on what's going on in their life. And not only is it going to help you with criteria, it's also going to contribute to that rapport and alliance, because when we're just being mechanical and kind of that goes into that person-centered stuff. And we're meeting the clients where they're at, and we're just trying to like see what's going on and how we can help. Even if the client's being a little evasive, I think they see that and that can go a long way. All right, so moving on to number 1, use longer or larger amounts than intended. Taking the substance in larger amounts or longer than you meant to do. That could look like a lot of things. So I got some examples on here on how you can frame it. And these examples I give are not all inclusive. I'm not going to catch every situation, obviously, but just kind of trying to reframe a way to think about these things so that when we ask them or trying to assess them, we understand kind of what that means in a person's life. So number 1, I gave, could you tell me about a night you got your DWI? So if you're working with a client, you got a DWI. Did you mean to drink as much as you did? And I'm like, the second one I got, they kind of go together. Have you ever stopped in for a drink after work at a bar, said you're going to have one, and the person ends up staying all night? Granted, I'm sure that if someone drinks alcohol and there's times in their life that might happen, we're talking about like on a regular thing. And even if it's only an occasional thing, if that's happening along with other stuff, that's criteria. You get where I'm going with this? You know what I'm saying? Even if the client says that, oh, once in a while, once every couple of weeks, that might happen. But typically I don't go to the bar, or I just stop in for 1 or 2 when I go home, or 1 or 2. If they ain't going to meet any more criteria, that's fine. If they also got some other stuff going on, yes. So no matter what, you're going to record it. But I'm just saying it's not going to impact them unless the other stuff starts adding on. The last one I got, have you ever stopped at a friend's, was offered a line or a hit of a substance and end up staying and going to buy more? And I think that's how it would look like in drug use. You know what I'm saying? Like they stop over their friends, maybe, I don't know, maybe they went in to buy a bag of pot or something, and they get offered a line of cocaine and they end up just staying all night and they end up going to get an 8-ball, and then it turns into a thing. That's kind of how that would look like in that situation. And again, there's lots of other situations. Those are just a few I gave to start thinking about how that looks like. And also I'll emphasize, this alone doesn't mean a client meets criteria. This is just number 1, they met that one. Number 2, wanting to cut down or stop using the substance. I'm sorry, I gotta move this so I can read what I wrote. But not managing to. Unsuccessful attempts to cut down on or quit. Examples would be for this one. Have you ever had a period of time when you were just done with use and quit? And I'll give them a second to answer that because you want to. And it's a little bit leading. I will completely acknowledge, but you want to hear what that person's going to say about that because A, we're trying to get that criteria, but B, it's going to tell you something about history. Whatever they're saying right now, whatever the client's feeling in that moment, it's important and it's relevant. I do not deny that. But also this might give you a glimpse into their history and a part to flush out at a further time. Because if there was a time in their life that they felt that on their own, that their use had gotten so out of control that they should stop and were able to do so, that says something. Not only does it say that they have the ability to, it also says that they themselves have felt that their uses reached a problem area in the past. So then I'll give them a second to answer that. And then I'll say, if they say yes, I'll say, can you tell me why you started using again? Because again, not only is that meeting the criteria, but it also is a glimpse into the history. And that's what this assessment is. It's both things. We're fleshing out criteria, but we're also trying to get the most accurate history we can. So like there's going to be so much more and so many things going to relapse, but right there is going to be an indicator. Like maybe they had 8 months where they were not using substances and then a family member died and they started using again. That shows that emotional coping and whatnot, that could be part of the relapse prevention plan when it's time to start doing that. You know what I mean? Because obviously this is a problem area in the past. Another example I have is, have you ever had a period in your life when you were in recovery or working a program? And then if so, why did you relapse? So like I would say A is more for that client that might never have been in treatment before, but has a history of use. B would be for someone who, and that person is going to be, the B person is going to understand the language more and what the way, the jargon that we use with that. So I think it's kind of the same question, just framed for a different audience. And that's the part of this. Like, I guess the whole point I'm trying to make, you got to speak the client's language and you got to like frame it in a way they get it and understand. Number 3, spend a lot of time getting, using, and recovering from the use of the substance. Time spent obtaining, using, and recovering from the substance. So when I went over this initially, I said it does not have to be all 3, but usually they go together. But even if it's just one. So what does that look like? Have you ever spent the day trying to earn money and once we're able, went and took the money and earned to buy drugs? I mean, it's common, especially in the city. People will scrap, people like do things like kind of hustle all day and they will probably be using all day too, because you make up some money and you go get some and then come back and hustle a little bit more depending on what the drug use is. And so that's a question, that's what that would look like. Have you ever shoplifted, scrap metal, performed odd jobs to earn money to use? Have you ever sold drugs to support your habit? I mean, if they're selling drugs, it's like almost full-time job at least. So if they're doing that, they're spending a lot of time obtaining, recovering, using, all the above in that. And then have you ever used more than intended and then spent the next day with a hangover or just too wore down to do anything else? And I think that's a good one too, because that is the recovering part. And again, even if you watching this training will drink on occasion, and I'm sure on a celebratory thing, maybe you had a little too much, you had a hangover. It happens. Alone, it means nothing. So if we go through all our criteria and then the client only reported that one time on New Year's that they hung over, yes, that's a criteria, but it's not enough and they're not coming to treatment. So again, it gives history and it gives accurate diagnosis. And just because they meet one, don't mean we're looking for the accumulation to A, even meet criteria to need services, and then B, the severity level to like determine how much and what's appropriate. Intensity, frequency, and duration. It's a very common term in any behavioral measurement, and I think it applies to substance abuse too. And that's kind of, we're not only trying to assess criteria, we're trying to assess intensity, duration, and frequency, so then we can also kind of develop the appropriate interventions or even determine the correct level of care. And the client coming in, we might be able to support them an outpatient, but they also might need detox inpatient right from the door, depending on intensity, frequency, and duration. Cravings and urges to use the substance. Strong cravings, urges, desires to use. So this one, when dealing with a life stressor or when faced with adversity, is it common for you to want to use? So like you're craving to use over some emotional coping to escape. After a period of use, if you stop, do you have urges or craving to use? So that would be more if we're talking like habitual use and daily use, like if they go a day or like even, I mean, we get in severe level in a couple hours, they'll be having strong cravings, urges, and desires. And this is also one that they all kind of go to relapse prevention plan. And once we get there, but I just emphasize how we're not only looking for criteria, but history. Not manage to do what you should at work, home, or school because of substance use. So the use resulted in failure to fulfill major role obligations at work, school, or home. So that could be a lot of things. That could be client got evicted because they didn't have their rent money because they spent it on drugs. Client split up with spouse kicked the client out, they dropped out of school, got fired. Like I gave the one example, maybe they're working at time of the eval, but they also, as you talk further, they had like 4 jobs, 5 jobs in the last year, and they keep getting fired or quitting due to their substance use and unable to meet their obligation. You get what I'm saying with that? That's what it's about. And that's also a kind of a spectrum level. I mean, client being homeless because they didn't pay their rent and got evicted, it's a little bit different than a client who might not be as far down the progression and still has failed to fulfill role obligations and quit and been fired, but to this point at least been able to like quickly bounce back and get another job. I mean, that will run out if we're headed on that path, but because these are the behaviors that go with it. But that's what I'm saying. There's always a spectrum in all this. It's not our job at this time to figure out what that is. Just if they have a history of doing this, and ways you can answer that is, have you ever lost a job due to missing work as a result of your use? Have you ever been spoken to or had disciplinary action taken due to being under the influence? And have you ever had trouble with your significant other, argued about use or money or the money spent using? Sorry about that. Have you ever missed a family obligation, graduation party, holiday due to being under the influence or recovering from the use the day before? And I think that one is a good one to ask, and it's a good one it's common, you know what I mean? And I think that, I mean, even in social media, you'll see this in movies and whatnot. And it's it happens. People, alcohol even, or drug use, they just blow off things that are important to their family unit. And it kind of starts that alienating process. And so it is part of that. And again, it's the criteria. Number one, if they make it, that's what they made. Because all clients aren't going to meet all of them. Some will, but all of them are not. Continue use even when it causes problems in relationships. Continue use despite social interpersonal problems. So these are examples. Have you ever continued use after promising family members or spouse you would not anymore and did so knowingly it would cause an argument, breakup, or conflict? Have you ever continued use after being legally mandated not to? And I think that one's important too, because if a person's on probation, parole, treatment court, and they're being mandated not to use, and they have that could go to that major role obligation too, or it could be this one in that situation. Have you ever gotten arrested for use? We're told to get into treatment, but continue to use anyways. So no matter what they're having like problems in their life and they continue to use. I think about this one with the DWI a lot. I said that there are cases where you got someone made a mistake. And I also find in those cases, those people tend to, I don't know if it's honest, but at least they know not to come to their chemical dependency eval with alcohol in their urine and smart enough to say that they haven't drank since. So that says a lot to me. You know what I mean? So if you got a DWI and they come and they were told you their last use date was yesterday, the day before their eval, and their urine's going to be positive for alcohol, ETGs in it, then I think that's a criteria, because if that says a lot to me. You just got a DWI and arrested. So definitely might have been something you want to be a little cautious around. And I think that the person drinking the day before the eval kind of just shows how they threw that to the wind. And I'll go even a little further than that. Even if they do not report use and they tell you they have not drank since their DWI, or they have drank in 3 weeks ago, but you get a positive urine with alcohol in it, again, this would apply there. And that also gives an example. Not only are we getting collateral contacts and like external information when making our assessment, we're looking at behavior too. So we got a client comes in, got a DWI 2 months ago, tells us they have not drank since that night of the DWI, but that on the day of the eval lie about it and they are positive for alcohol, they meet this criteria. And it's definitely a huge flag on the play. You know what I mean? Because not only then are they still meeting this by continuing use despite the social problems, they're also knowing that it's bad and they're trying to lie and cover it up. And that says a lot to me. You know what I mean? Giving up important social, occupational, or recreational activities because of substance use. So social, occupational, activities given up or reduce. So the way to frame that: before starting use, did you ever have any hobbies, activities like belonging to a sports league, drawing, painting, playing on an instrument, or going fishing, hiking, exercise that you no longer did or did not did as much because the person was too busy using? I mean, you're not gonna say that part. You're gonna say after use started. Have you ever stopped hanging out with friends, either by choice or yours, after use began, as they weren't into partying as much as you? And I think that one is also a common one, especially I mean, you look at progression in someone that kind of progressed from adolescence and kind of their friends were their friends that they clicked and progressed with. You might not see that as much as someone that might have went through a life stress or a problem, turned to use, and then like they're kind of positive role models and quality relationships. Not only do they not want to deal with the person as much anymore, but that person might also turn away from them because they're not giving them what they need. They're kind of seeking out the darker path in life and looking for new people that are into the stuff they're into. So they're hanging out with using friends more than those quality relationships. So that can look either way. And those are a couple of ways how to frame that. Using substances again and again, even when it puts you in danger. Use in hazardous situation. Client reports traveling in dangerous areas, obtain substance use, dirty needles, and driving under influence would be a few examples of those. And I know this is I'm not gonna lie, this is a funny one to me. I worked in Rochester a long time and I never even thought about it. When I got out into Dansville and CASA, that was the first place I worked. The counselors there, they would count that if a person drove to Rochester to go buy, if a person drove to Hudson Avenue to buy heroin, that would be use in hazardous situation. Obviously, driving under the influence, IV drug use, dirty needles, like all that's part of it. But even that too, and like I remember the first time I heard it, I thought about it for a second, and I gotta agree with that. I gotta agree with that thought, because like when I lived in Rochester and I lived in the city, like that's your community. So even though it might be dangerous, you don't necessarily think of it like you're going to do something dangerous because you just live there. I think if you live in Dansville and you're driving to Hudson Avenue, there is no business that a person has there, and it is definitely very dangerous for them. So I definitely think that can fly. But some other ways I see it, I see you were arrested for a DWI. Did you just not think you were as intoxicated as you were that night compared to others when you maybe leaving the bar? So not only are you looking for a little bit of use longer intended there, when you're framing that one, you're kind of also looking for a history of driving under the influence. And if they openly report that they drive home all the time, then that's also it. When you buy drugs, may I ask, where do you go to buy? Is it local or do you drive to the city? And if so, what neighborhood? When returning from Rochester, do you wait until you get back to use or do you do a little bit before heading back? Because that also says a lot. Client drives all the way to Rochester, buys a bundle of heroin, I don't think that's going to happen, that they're going to drive all the way back to Dansville. But if they're under the influence when they drive back, that's also definitely use in a hazardous situation. Continue to use even when you know you have a physical or psychological problem that could have been caused or made worse by the substance. Continue to use despite physical and or psychological problems called or made worse by it. Now, this one I didn't even frame anyway, because obviously if the clients can report accurate, it's one thing. I have had debates with colleagues, and at the end of the day, this is going to have to be your choice in how you deal with this. But my personal thoughts around this one, we live in a modern day and age. 20, 30 years ago, when we weren't as comfortable to have these conversations, or doctors may not even been up on it, was like how a client's use impacted health. Maybe they kind of thought no, but I think it used to be more back in the day. That's a person's business, unless it was really truly a problem. We're in a time where I know without a shadow of a doubt, if I have a client who is diabetic, their doctor has specifically forbid them to drink numerous times. And if they continue to drink, their doctor probably yells at them every time that they go in there for drinking while having diabetes. And same things with blood pressure. Just like I know if a person has a bipolar disorder and they use meth or crack cocaine, I know that is going to like severely exacerbate their mental health symptoms. And again, there's a gradient of this, but we live in a modern educated day where I know not only were they like talked to extensively by their doctors when their treatment course began for whatever their co-occurring disorder was, they were specifically given instructions not to use substances. And probably when they went and picked up their meds, we got that big thing on, don't drink under this or use other substances that might cause this. So we know this one, I think, there's might be some gray areas where you might need to ask, but for the most case, we know them big typical person has heart problems. They shouldn't be doing cocaine. They shouldn't be drinking. Person like they know, we know this. We know that we live in a society that the client knows this and has been educated on this by their doctor when they started their treatment course there. So I think this is one of those ones that we need to use our clinical impression, because if you ask a client who's bipolar, if they thought that the meth exacerbated their mental health, they're probably going to say no. Maybe because they don't know what exacerbated is, but also because like that they just don't see it that way. But we know that it does. So in this one, I think we have to flush out and we have to use our clinical judgment here. You know what I mean? Because it might be one that the client might not totally know extent, but that doesn't mean it's not happening. You know what I mean? There's a few like that kind of goes both ways. This one, I would say concretely can be that. I mean, don't get me wrong. There's going to be clients that be like, yeah, I know I shouldn't do it. But there's other ones that be like, no, I don't feel it does. The doctor tells me it does all the time, but I don't think it makes anything worse. You know what I mean? But that is not an accurate report. We know that it makes it worse. And again, we're objective in this thing. We're objective when we're doing diagnosis, we're assessing, it is an objective process. Number 10, needing more of the substance to get the effect you want, tolerance. So we already talked about tolerance a little bit, so I'll just frame it a couple of ways and we'll talk a little bit again. On the night you were arrested, what was your BAC? Per OASIS, 0.14 or higher, that is an indicator of tolerance. Or if the client tells you they had 6-8 drinks or anything like that, that's going to indicate a tolerance. When you first started use, I assume it did not take much to feel an effect. Has that changed? And do you find you take more now than when you first started to get the similar effect? You know I think about that like with marijuana or cocaine. Like, again, with the harder drugs, you're not even going to get a little pushback from this lab because the client knows that. I mean, clients smoking $200 with crack cocaine or shooting 2 bundles of heroin a day, they know they have tolerance, and they also know they're using their level. They're not going to try to be evasive about this. You get someone else, marijuana, alcohol, like, you know, I think typically when people start smoking weed, in my experience and observation of life, like, might be about a teenager, took a few hits and they're feeling the effect. Now they're smoking a gram or 2 a day. That's tolerance. You know what I'm saying? You get where I'm going with that? Same thing like I already gave the alcohol reference earlier. Someone's like, first time they drank, they had a couple, they were feeling loopy, went to bed. Next couple, 2 more. And at this point, they're drinking a 6-pack a day. That's tolerance. You get what I'm saying? So I think a lot of times clients may report this one accurate, but also if you get their impression or not based on everything else they're telling you in the assessment, and then they try to say they don't have tolerance, but they already reported that they, first time they drank, they had 2 beers and now they drink 6-pack a day. You don't need to you got to use your clinical impression on that and science and the things that you know, because now they need a 6-pack and they barely get a buzz compared to the time when they started, they had 2-3 drinks and they were drunk. That's tolerance. You know what I mean? Whether they're saying it or not, that's tolerance. All right. Development of withdrawal symptoms, which can relieve by taking more of the substance. Withdrawal, client reports experience shakes, insomnia, vomiting, runny nose, and any withdrawal symptoms. This one for me, again, I think that this one is far, if they have it, they have it. I'm with that, but I also take more of an effect. I believe that psychological withdrawal also goes in with cravings, urges, all the other stuff that we've been assessing. So it's not that it doesn't exist. I completely acknowledge it exists. But this one, I think of this one in physical withdrawal symptoms only. And I think most counselors do. I am never really having a conversation about it. Maybe it's just on my frame because I talked about psychological withdrawal recently. But if you know a client, again, this is also one I don't think a client's going to lie, especially if it's opiates. They're probably here that maybe the goal is to get Suboxone. They know they got to be honest anyways. They have a history of like severe alcohol, benzo, things that actually cause withdrawal. It's usually used on a level 2 that they know that they can't hide that, or maybe they don't want to because there's reasons, maybe they want help, whatever the case may be. So it's not something you kind of like, if it comes down to it, obviously you got to use your clinical judgment, but I don't think it's one of those situations that you will a lot. Typically they'll report correctly, but I also didn't go in a bunch of examples because it's a little bit of common sense. You know what I mean? Someone's reporting they take 15 Vicodins a day, that they're going to have withdrawal symptoms. Someone reports they're shooting 2 bundles of heroin a day, they're going to have withdrawal. Someone says they're taking a bunch of benzos every day, they're going to have withdrawal. Someone starts drinking as soon as they wake up until they go to sleep and they drink half a gallon of vodka or a couple pints a day, they're going to most likely have withdrawal. You know what I mean? They might say they're not having withdrawal or they don't know because they have not stopped use for the last 6 months and then they've never gone a day without it. So in that case, you definitely got, but they're also not going to deny that they probably do have withdrawal. They just maybe didn't experience symptoms because they continue to use. Severity of substance use. Already talked a little bit about. We got mild, moderate, severe. So mild is 2 to 3 symptoms. For CASA, first time in treatment, usually the mild diagnosis, we do the addiction awareness course. I think even if your gut is telling you that you know there's more, and maybe they were on probation, and because probation and parole are good with the PSI and they're good source, but not always. Sometimes they don't have this history recorded. You got the PSI, probation says, I don't know, I got a feeling. PSI didn't really say much. They haven't had a positive screen. So, but you have this feeling like you know that minimize and justify. I think it's completely appropriate that if all we get is 2 to 3 symptoms, mild diagnosis, put them in addiction awareness course because the truth will reveal itself. If there is more, you'll see poor attendance and you'll start to see positive screens. If there is not, and it's an accurate diagnosis, an accurate thing, most likely the client's going to come to every session and be done in 8 weeks. Doesn't say everything, but I do think it says a lot. Moderate or severe, they're going on a regular course of treatment. Moderate's 4 or 5 symptoms indicating moderate. substance use, I would say for that one, if the client, I don't know how to put this because I don't want to give bad advice. A severe diagnosis is definitely going to go to stabilization, or they're definitely going to go to inpatient. And that's they're using daily active use, pre-contemplative, contemplative stage. Moderate, I would say, would be ERS group. If the client is reporting, and again, just like the addiction awareness, even if we're off and then they'll show itself, we can always move the client back to stabilization or recommend an inpatient setting. So to get started, it'd be fine ERS. But when I think about ERS is probably still contemplative stage. So the client might not have complete buy-in, but you don't want like daily and excessive use. You know what I mean? For ERS is like, I think like use to not a severity level, or maybe they were in stabilization and they stopped using heroin, but continued and still using marijuana. Like there might be still a small element of use on ERS, but if you're putting someone in ERS, I think that they should be, in your best guess, having a good fighting chance of going a typical outpatient track and finding sobriety. Does that make sense? Like just stabilization to me anyways, and I'll talk to people, I think we look at it a little bit different. Stabilization to me is almost a harm reduction tactic. Stabilization, even though it's 5 days a week, and it seems like it's more, and it is, it's more support, but it's also availability where the client can go every day. I mean, I think any of us have been doing this for a while, especially if a client's actively using, maybe like very resistant inpatient, and we're working on that. But right now we want to provide service. We know that client's not going 5 days a week. No way in hell. I mean, like, but just the fact that they can go on the day that they decide to, or maybe like in getting to the contemplative stage and are not ready for a full buy-in, but every once in a while they feel the need to go to and they start to use that resource. I think that's a good indicator that we're heading in the right direction. So yes, it is about severity level, but it's also about level of support when we're going stabilization route. So because of that, I would think that ERS to start, that goes ERS, PRS, recovery enhancement. That's our typical treatment course. And we know it's going to be bumpy and not perfect, but we want to, excuse me again, sorry about that. Try to at least gauge that the client has, that's the best shot. Does that make sense? Like that's a competent and ethical choice to start in the ERS. And I would say moderate, you would see that more. We get into severe diagnosis, they probably need stabilization, and realistically probably need inpatient and detox. Clinician can also add some specifiers in early remission and sustained remission. And I only talk about those two. Let's talk about those two first, and there's another one. Early remission, the specifier is used for at least months, but at least 3 months, but less than 12 months. One or more criteria for dependence or abuse have not been met. Sustained remission, the specifier is used if none of the criteria of dependence abuse have been met for a period longer 6 months. Important to note, it may be like a person could be early in sustained remission for one substance, but not the other. So a person might be in early remission for their cocaine or heroin use, but still meets criteria fully for alcohol, cannabis, or something else. You know what I mean? And same thing with sustained remission. I mean, I think if you do this, you'll see there's someone might not have done heroin for 2 years, but they are doing cocaine regularly, kind of thing. You know what I mean? And again, this is not a specific thing. It varies, but that's the example it would look like. So a person can be early and sustained for all substances, but a person can also be early in sustained remission for a specific substance, but still meet criteria for another. Further specifiers on maintenance therapy. Back to the opiate, person might be in no use of opiates for 2 years, but been on Suboxone. So it would be like opiate diagnosis, sustained remission on maintenance therapy, or just on maintenance therapy. And that maintenance therapy and Suboxone, methadone, Vivitrol. In a controlled environment. This one I want to talk about a lot because this is one I think there's also a misconception. I am serious business about this one, and I'm going to tell you why. I'm even going to tell them something personal. I don't tell a lot of people. Well, if you know me, I probably told you, but in a controlled environment. This specifier uses the individuals in an environment where access to alcohol and controlled substances is restricted and no criteria for substance abuse has been met for at least the past month. Example, these environments are closed, supervised in substance-free jails, therapeutic communities, inpatient, intensive residentials, locked hospitals. So like, not that it's impossible to get substance, but it's very hard. That's a controlled setting. You know what I mean? And this one, I think like counselors struggle with this one. And what I'm gonna tell private, like I did 8 years in prison. And I'm telling you, yes, that's true. But I'm also telling you that when a person's transitioning from society, from prison to society, it is a delicate time. So if they have a substance use history, not only is there a lot going on, a lot of stressors and a lot of things they got to deal with, it is just good to give them that support. Because even though we treat substance abuse, we also do a lot of other things, don't we? We help people get housing, we get link people with DSS, we help them with rides, like medical appointments and stuff. And just the fact that you can get this person in on that level, even if they just did 3 years and reported they didn't use for 3 years, I think that that's still valuable. You know what I'm saying? Does that make sense? Like, so I think that we need to start thinking about it like that, because I think a lot of times the client comes in, and a lot of times not even on the up and up, where they might even just use last week and just trying to get out of treatment, and they're going to try to say, I just got out of prison, ain't using 5 years, I don't need this. And the counselor kind of buys into that. That is a no-no. You know what I mean? I will tell you that if you want to ask further and are comfortable in prisons, like there is treatment programs. The Fed's got a program that's like 18 months intensive, and it knocks time off there. They can get out 6 months earlier or a year early. State prison has CASAC program. I know it sounds like CASAC, but it's the T at the end. And if that person did the CASAC program, I'm going to give credit for that. And so I'm not saying a person needs to go to stabilization or even ERS, but I think at least PRS. You start 2 days a week, individuals maybe for once a week for a while, and then it's a good treatment recommendation with that, because you'll know. And you'll also know if the client's getting right to and doing good, going to groups and it's coming to you and in good spirits, you'll know that maybe you can go out bi-weekly. And then once they PRS, everything's going to be on the right track. And at the same time, you've helped them. You helped them with some job stuff, some vocational stuff like that, because they do meet criteria. As far as diagnosis goes, I am not lying, nor am I just saying this because of the training. I don't care if someone did 10 years. They could have done 10 years in prison. I am diagnosing from the day they went to prison, like the day before, the use from the day before, nothing to do with the 10 years. If they were told me that they were using 200 hours worth of crack and then they got arrested for a robbery or something, I'm diagnosing the 200 hours worth a day of crack in controlled environment. And I'm recommending treatment PRS. And that's what I'm doing with the client. And I think that it's unethical to do it any other way. And I say it's unethical because I think that we have all been taught, and we know the rate of recidivism rates and how substance use and criminal activity go together. And don't get me wrong, I know there's lots of criminals that are just criminals, and maybe it didn't have to be around use, but I think like 80% of the time it is. And if you have a client that was using 200 hours worth of crack cocaine a day, and they tell you they didn't use crack cocaine in 10 years, A, the controlled environment, B, there's not a lot of crack cocaine in prison because it's very expensive and it's like hard to get in. You know, and like no one can, opiates, heroin's popular in prison, marijuana's popular in prison. I'm not going to say that you wouldn't see cocaine and other drugs, but like no one's going to sustain a 200-hour crack cocaine habit. They probably cost like $10,000 a week. You know what I mean? And you just don't make that type of money. But so you can't count that. And that person had a severe diagnosis. And just because they were in a setting that they were kind of protected from that world it doesn't mean anything, but it doesn't mean recovery, and it doesn't mean that they are healed. And that's why I say it's unethical. And we need to diagnose based on the day before they went in. And same thing for an inpatient in rehab. I know it's common, like, don't get me wrong. We get someone that goes to inpatient and then does even our intensive residential program. I'm not saying they need stabilization. I think they're still early in recovery though. I mean, it was only 4 months ago, they were severe diagnosis and use in hazardous ways that met inpatient criteria. It's only been 4 months. That person's very early in recovery. That doesn't mean they need to go to relapse prevention. The stages of group mean something. I'm also going to do a training on that in the near future. They kind of go together. I know it's not perfect. I know we're going to be flexible where we can, and we're going to try to make treatment plans that like suit a client's needs, but holistically, they should guide us in our decision making. And this goes with that too. And I'm sorry, I just see the controlled environment one get off a lot. And I just want to say, from a convict, that is a mistake. Like, person needs help. Even if the person really doesn't, I went back to the college. Maybe it's like that. Man, the college kids, they grow out of it. Adolescence, I think it's hard. You don't know, is it adolescence or is it dependency? You know, it's hard to see sometimes. So even if the person went to prison at 20 years old and substance use related, and maybe they kind of grew out of it, just the fact that because that transition is so difficult, I think it's just good practice anyways to wrap that person in support and give them some help. All right, I do another video here.
Integrated detection and assessment of both substance use disorder and mental illness is most effective if it is done at the same time by the same clinical team. Assessment usually occurs over time during the engagement and persuasion stages of treatment. During the assessment, the clinician learns about the context of substance use, as well as symptoms of abuse and dependence, so we can clarify the diagnosis. The comprehensive longitudinal assessment describes functioning, symptoms, treatment, and interactions between all of these. In this type of assessment, mental illness and substance use information is integrated. It's helpful to get information over long periods of time during different periods of functioning so that you can assess how mental illness symptoms and the substance use disorder interact. More often than not, you'll need to get this information from clients in bits and pieces over many meetings. You'll also want to include information you get from records and from family members. In a moment, you'll see a part of an interview of a young man with schizophrenia and a substance use disorder. The interviewer is trying to do a comprehensive longitudinal assessment. Notice how she uses a non-judgmental attitude that allows the client to be honest about his substance use. Although you won't see enough to be able to make a diagnosis, try to see if you can figure out what stage of treatment this client is in.
So you've got some really good things going on. You've got.
Oh yeah, you know, I try to keep myself busy and stuff. You know, I mean, though I drink, you know, on and off every day, pretty much. You know, but that's just my thing. You know.
Yeah.
Takes the edge away from life. You know what I mean?
Drinking takes the edge away from life. Yeah. So there's some good things about drinking.
Yeah, there are some good things. You know, it isn't all bad. You know, but if you abuse it, it's really bad.
Yeah.
You know?
Can we talk a little bit about the impact that your drinking has had on your life?
I don't know. I really I started drinking heavy only like 4 or 5 years ago, I think, or something like that.
That was in relation to the medicine you were on?
The held off, Decadate. Yeah.
It helped with the side effects?
Yeah, because it was really ripping me apart inside, you know, and no one would do nothing. They'd give me Cogentin, but Cogentin made it worse. Dried your throat up and stuff.
So the alcohol took the edge off?
Oh, yeah. It helped a lot.
Ellen, how old were you when you had your first drink ever? Just a regular drink?
About 5 years old.
About 5? How did that
I had
happen?
a toothache, and my parents gave me some whiskey.
Did you remember how you felt?
Huh?
Did you remember how you felt?
I felt good.
Yeah, did the toothache go away?
Yeah, toothache went away, and I went to bed, you know. And so I would drink on and off, like, as a kid, because my sisters, they used to fix pina coladas and stuff like that. And I wanted to be grown up like them, you know, drink coffee and drink this. And so I'd drink. They'd give me a White Russian once in a while.
And how old were you then?
Oh, this is all through my youth.
So maybe around 10 or so?
Yeah.
10, 11?
I mean, during Christmas, they'd break out this yellow stuff, I don't know what it was. It comes in a...
Oh, the stuff you make Harvey Wallbangers with.
Yeah, probably.
Yeah. I forget what it's called, but I know what you're talking about.
Yeah, liquor taste to it. Yeah. It's really good. Expensive.
Yeah.
But yeah, they break it out during, you know, holidays like Thanksgiving, Christmas, something like that.
So when did you first start drinking for yourself?
Regularly?
Yeah.
Oh, geez, I really, I would say about 26, 27, something like that.
So as a teenager, you didn't drink much?
Oh, I drank, yeah, but I mostly smoked marijuana.
Okay.
I smoked a lot of grass.
And when did you start? What age were you when you started doing that?
About 15, 16.
Okay.
Yeah.
And then you were just kind of drinking then about once a week? Maybe?
Yeah, I wouldn't drink like all the time. I was a social drinker.
You started out as a social drinker. Okay.
But, you know, I grew up where, you know, if you're going to drink, you're going to get drunk. You know, that's the whole point of drinking, you know. You don't drink just...
Don't drink to enjoy it, drink to get drunk.
Yeah, you drink to get drunk. You know, it's sort of like my generation.
Yeah, well, I think a lot of generations grew up with that.
Oh, yeah.
So you started smoking pot when you were around 13 or so?
About 14. 15. Yeah.
And how much were you smoking?
Not much. I could never afford it that much, you know. But my friends would always get me high and stuff, you know.
So a few times a week?
Yeah, a few times a week.
Yeah. Was it pretty pure stuff Alan, or was it laced with stuff?
No, it wasn't laced with anything. It was regular weed.
Yeah.
No, I can't say I had any angel dust or anything like that. No.
Okay. When did you first start? You mentioned drinking coffee. Do you use a lot of caffeine?
Do I use a lot of caffeine?
Yeah, do you drink a lot
I drink
of
a lot of
coffee?
water.
Okay. Do you drink a lot of soda or
No,
coffee
not really.
or tea?
Not really.
Okay.
I have soda once in a while, but
What other drugs have you tried? Have you ever tried LSD?
yeah, I've definitely done a couple trips.
Yeah. How old were you when you first started to do that?
Geez, I was like 17, 18.
Okay. And how long did you use LSD for?
I did like 3 or 4 trips.
Okay.
3 or 4.
Do you remember how you?
I remembered the whole trip.
Yeah. Ellen, how come you stopped after 3 or 4? Did you just?
I don't know. It's just like friends faded away,
Okay.
connections got cut, I don't know.
Did you like that effect?
Oh, yeah.
Yeah.
Oh, yeah, I like acid.
Okay. What about speed?
Not really much of a speeder, no. No.
Cocaine?
No cocaine.
Over-the-counter medicines?
Oh, yeah, I had my time doing that.
What
Like
kind of
Benadryl.
Yeah.
I took 24 of those pills. I mean, goddamn. Wake up, you don't even know where the hell you are.
Right. When was the last time you used Benadryl?
Oh, I swore it off. That was back in 92, 93.
Oh, see, it's been a long time.
Yeah, it's been a while.
Yeah. Okay.
Yeah. It's a cheap man's high.
Yeah. Well. Yeah. How about pills? Do you ever get any pills? Like
No, I don't do
Klonopin,
Valium. No,
Valiums,
no.
anything like that?
No,
No.
no, I don't do that.
What about heroin?
I've tried heroin once.
How long ago?
Back in 94, I think. 94, 95. When I had Section 8 in Portsmouth. I had a really good apartment. I let people into it, and they got me evicted.
Did you just use it a few times?
Yeah, just a few times.
Just smoke it or shoot it or
Snorted it.
snorted it? Okay.
Yeah.
Remember how it made you feel?
Yeah, real good.
Yeah.
Yeah, and I didn't get sick. You're supposed to get sick, I guess. But I didn't get sick. I just kind of like nodded out.
So when was the last time you used heroin?
96, I think it was.
Okay. And when was the last time you smoked pot?
What? Last month.
Okay. Right. And when was the last time you had something to drink?
Just yesterday.
Yesterday. Last night, maybe?
Yeah, last night.
Yeah. Okay.
When's the last time you had a drink?
When was the last time I had a drink? That's a good question. I had a drink last weekend.
Last weekend,
I had a
huh?
glass of wine.
Wow, that's good for you. They say red wine is very good for you.
Well, actually, this was pink wine. So.
Pink, huh?
Yeah.
I only like the red, really red wines.
Yeah, we had a celebration. So.
Well, that's good.
Yeah. How about what medication are you on now? What are you taking?
Well,
I wanted to pause it. There quickly. I do like the video because I know the main reason I showed it is the conversation style. If you are doing an assessment, that's what you want to do. And I know that we have a computer in front of us and we're tempted to jot it all down and ask questions, and it kind of guides us. But the more artificial we are in our question asking, it's more likely we're going to get artificial information. So the conversation style is what I really wanted to show with this video. And there's more good stuff in there too, but I also had to stop it because I do think her sharing that she had a drink last week was a little bit too much self-disclosure. That's not the message we want to send, and that's not that, especially when we get to know a client. I don't think there's nothing wrong with ever being genuine and sincere and like kind of being personal, but that one would be more like, what's that got to do with us, or how's my history? We're not assessing me. I mean, and there's ways to ask it. I'm not saying being sarcastic or anything's the way, but I did feel it was a good time. So I did reset by accident. Fast forward now and put the video back on.
And when was the last time you had something to drink?
Just yesterday.
Yesterday. Last night, maybe?
Yeah. Yeah, last night.
Okay.
When's the last time you had a drink?
When's the last time I had a drink? That's a good question. I had a drink last weekend.
Last weekend.
I had a glass of wine.
Wow, that's good for you. They say red wine is very good for you.
Well, actually, this was pink wine. So.
Pink, huh?
Yeah.
I only like the red, really red wines.
Yeah, we had a celebration. So.
Well, that's good.
Yeah. How about what medication are you on now? What are you taking?
I'm on
now?
Zyprexa and Haldol.
You're still on Haldol.
Yeah, they won't take, but it's been reduced from when they used to shoot me up every week. I mean, that stuff was painful.
Yeah.
But now they just shoot me up once a month.
Okay.
So which is very good, you know. And the Zyprexa is supposed to level off with what's it called, Haldol.
Do you know how much Haldol you get once a month?
3/4 of a cc.
Okay. All right. And how much Zyprexa do you take a day?
I take 15 milligrams a day.
And you said that the voices have gone away.
Yeah, they have.
Yeah. Okay. Any other drugs that you might have used that I might have forgotten to ask you about? Mushrooms?
No, I never really had mushrooms. No.
Yeah. What about ecstasy?
No, I won't touch that stuff. No way.
Yeah.
I don't trust it. You know.
Okay. Oxycontin?
What's Oxycontin?
That's the new drug that's out.
Oh, really?
Yeah.
I don't even know. I'm not in touch with the.
Oh, well, I have to keep up on these things, Alan. It's out on the street. It's a painkiller. It's an opiate.
Opiate, huh?
It's out on the street that some people are abusing
Yeah.
pretty regularly.
Ever heard of ice?
Mm-hmm. You use that?
No, I heard it's like really, really potent.
Yeah.
Like sort of like peyote.
Yeah. What about methamphetamine?
Never heard of it.
Crystal meth?
Oh yeah, crystal meth. I heard of that, but I never tried it.
You ever had a blackout when you've been drinking?
Oh yeah, I've had blackouts. You know, not lately, anyways. But you know, I'd have blackouts once in a while.
Do you ever get shaky the next
Yeah.
morning?
Yeah, I get shaky and stuff.
Is it hard to eat the next morning?
No.
You can eat okay?
Yeah.
What's your tolerance like, Alan? How much can you drink?
I can't drink a whole lot. I mean, 3 beers and I'm pretty much toasted.
Okay. Has it always been that way?
But they're 16 ounces.
Yeah, 16 ounces. Well, I think that's
That's
fair.
about 4 or 5 beers.
Yeah,
Right?
yeah. Okay,
About
3
that.
16-ounce beers and you're pretty toasted.
Yeah.
Is it when you were younger? Could you drink more?
No. I just drank for the effect, you know, and once I had the effect, you know, it was growing up socially. Like, you know, my parents were okay with it and stuff like that. But
So, at any point, did you ever drink like 2 6-packs a day? I mean, were you ever like a guy who used to really pound them back?
I could never pound. I mean, I drink whiskey and I have just a glass of that.
How big a glass? Are we talking a 8-ounce
We're talking
glass
like
or
this, yeah.
like a shot, like maybe a little juice
About
glass?
4 shots.
About 4 shots. Okay. And how does that make you feel?
Good. Makes you feel good, yeah.
Do you tend to black out when you have both whiskey and beer?
Beer?
or just-
No. I just drink to a certain. Sometimes I don't even finish the cup.
whiskey,
You know, I just drink. When I feel tired, I go to bed.
Okay.
You know?
All right. You ever been arrested for DWI?
Yeah, I've been arrested for DWI
When?
back in '88.
Okay.
I haven't had a license since.
Really?
Yeah.
Did you go through the whole course and?
I went to Amethyst. They said do 6 months of AA, and I said I'll never do it. And so, you know, I never did. I'm very stubborn.
Yeah. So you haven't had a license since then.
Nope, and I'm a habitual offender. So that,
Tell me about that. What do you mean by that?
well, driving habitually without a license.
Okay. Okay.
I got caught in '97, and I did 8 months. You know, 4 months, good time. 8 months. You know, they say if I get caught again, I do 1.5 to 3 up in the big house.
So are you currently driving without a license?
No. No. I wish I was, man. I don't know.
You want to take that chance?
I don't know.
Yeah.
I have to go to a different state,
Yeah.
not New Hampshire.
I think it's called like a geographical cure.
I'm stopping it there because that's really all I wanted to show today. When I was looking for a video to kind of reflect all this, all I could find was hour or 2 long trainings on assessment and criteria and whatnot. And I just wanted something quick that kind of showed you how it should be as natural as we can make it. You know, obviously this video is a little dated, so they might not have been relying on computers like we are, but even in our setting, I think the initial part of that assessment should be as much like that as possible. I mean, look how much information she got from Ellen. She didn't ask the criteria verbatim because the criteria has changed, but not much. Even back then, they were looking for the similar things. And she knows the criteria. And so in that conversation, she can flush it out. I think there's nothing wrong with like keeping a notepad note if you need to jot something down to remember. But when you get into that fully like document and talking, not only does it kind of take the personal part out of it, you're also kind of in that mode and reading off the screen, but you want to make it as natural as possible. I'm not saying the whole assessment's like that. I think that you should start out like that. Start out with 20-minute, half an hour session. I know me personally, when I'm doing evals, and I would recommend it, I'm getting documented during the eval within the time frame that I have as much as I possibly can that I'm going to need. But I can also, and I'll even in my eval, I'll kind of write in shorthand so I won't forget what it is. But then after the client leaves me, I sit down for like 20 minutes, finish it all out, and then that's that. I also, again, it's a preference, and I know that it's not preached across the agency. I do not believe in the second eval. I am rooted in motivational interviewing, I would say, and I always resonated me, the research where it was like 3 groups. One group, they told like, hurry up and wait and come, we'll get back to you when we want you to start treatment. The other group, they started treatment right away. And then the third group, they gave like self-help stuff and told them to wait. And what they found was that even the people they gave the self-help stuff to, and the people they immediately engaged did well in retention and well in treatment completion compared to the group that they were told hurry up and wait. They continue to use because they did exactly what we told them. And my personal opinion, and again, you're going to have to figure that out in your practice, is when we're telling them, the client comes in, especially if we got severe diagnosis and some stuff going on, and they tell us all this stuff, and we tell them come back next week and we'll talk a little bit more and act like it's not a big deal. I think that sends a message. You know, I think in the eval, it is very important to create that bond, that alliance, start building rapport, and also create that this is serious and I'm taking you serious and you should take it serious too. And we can't do that by telling them come back, come back, come back. We want to start that process as soon as we possibly can. So I would strongly recommend that. And I know that sometimes that might take an extra 20 minutes, half an hour after the eval to type it out, because after you're doing for a while, you know the pieces that you know the client for, that you need the client for, and or like I said, I'll just stop like a short sentence, but it'll cue me. It's enough to cue me what was said, so that when I'm accurately documenting once the client leaves me. Because I mean, you want our evals to look good and represent our work, so you want it to be fluid and you want it to be cohesive, but that doesn't necessarily, you need to sit down and write it like that at the time of the client. The client, you just need to gather information and everything you need to get to that point. And yeah, I'll spend 20 minutes, half hour after the client leaves me, but I think it's worth it because I'm also sent the orientation appointment in 2 days, you know what I mean? Or next day. All right, moving on. Common misconceptions. There seems to be a common misconception in practice that assessment is based solely on what a client reports. So I already touched on that a lot. It's not just the client report. It's the behavior we're seeing. It's if they're lying about their use and the positive screens. It's about the collateral context. It's about history, past treatment history, what our mandate information has. It's gathering all that information and putting together our assessment. You know what I'm saying? Like, even back to the case I got where I might finish the eval after, that doesn't mean that, so I got 4 criteria right then, and that's enough to get the ball started. I'm scheduling that orientation appointment, even though I know I'm still going to reach out to this collateral context to get more criteria if it's there. You know what I'm saying? That doesn't mean that we can't complete our eval, update our diagnosis later, whatever the case may be. We want to start that ball rolling. And again, it's not just what the client says, because if you have an invasive client that doesn't want to be there, they could have a horrible history and sit there and tell you that I don't even know I'm there, I've never used drugs in my life. And that is an extreme case. I do think that I've seen it happen a couple times, but like I'm talking blatant lie, nothing, unless you did your homework and went a little further and kind of peel the layer back and just stop by with the client reports, then we're not helping anybody. And we're not kind of working in an ethical and professional way. Because like I said, when I started the training, this is our job. And there's subjective parts and objective parts of what we do. Always the assessment, there's nothing subjective about it. It's all fact-based, it's all what we see, and it's all what we can prove. Because that's another thing too. In no way ever am I saying make anything up. You cannot give them that criteria unless you can support it. And I don't mean you can support it with like a legal affidavit, but you got to have something that's going to back up how they meet that criteria if it's challenged. I'll also tell you that I've been doing this 8-9 years maybe, and I've only had one of my diagnosis challenged, and even that was kind of, I mean, the guy was DWI IDS system. He had just had treatment recommended 2 months prior from a different agency and was trying to treatment hop, and so like it wasn't much there, but only one has ever even like said blatantly that they felt that was wrong. Even then, it was still no proof, because I've always been that way. I'm not going to put it unless it's there. You know what I mean? So while a client report is critical in assessment, we must use all sources available to make an accurate diagnosis. And I got a little list here: collateral contacts, gathering and evaluation of outside paperwork, including the following: court paperwork, pre-sentence investigation, alcohol and drug screening results, previous and current treatment records, history in the IDS system, motor vehicle reports, that might say the DAC if the client doesn't, and medical histories from current reports from physicians when appropriate and when needed. So that is all I got today. And I hope this helps everybody. And I hope that helps our clients get served better and kind of get their problems assessed better in the problem areas so we know where to intervene. If you have any questions, feel free to email me and I would be glad to answer. Have a good day.